Hi, thank you very much. Good afternoon, everybody. It is afternoon. I just had to think about the time as well. So I'm a CKD specialist nurse for the Wyre Forest Health Partnership, which is a new role. It became apparent that not many staff or patients knew about CKD, and they also needed a bit of help with coding CKD as well. There is very little understood about it. That's what I found. And as the prevalence of CKD is increasing, next slide, please. Due to other health conditions like high blood pressure and diabetes, which are common factors for CKD, this then increases the demand and time. So it was put to us to do education and group clinics, which patients have really given good feedback, which I'll come on to later. So basically, they're offered a face-to-face, patients are offered a face-to-face appointment or a video group consultation. And following the pandemic, I think patients are still a bit wary about coming into buildings, and whether they want to just do it via computer, that's their choice, which is pretty good. And they seem to like it that way. Next slide. So how does it work? So basically, I call it the recruitment process, but it's not really a recruitment process. When I speak to patients that have been newly diagnosed with CKD, I will phone them and let them know that they do have CKD and offer them a statin, talk to them about CKD, and offer them a video group consultation or the face-to-face clinic. And I explain to them that there's other people there as well that they can meet who are newly diagnosed as well in the same boat. And this is what the room looks like. Thank you. So I set it out so it's not so formal, and basically I have an education board in there as well, which I made, and the patients all get an education pack as well. So we start the clinic usually at 11 o'clock, and it goes on till 12:30. Patients usually bring somebody with them because unfortunately their patients are a lot older, so they sometimes bring somebody with them and they have to sign a consent form as well, and I discuss about confidentiality and ask them to sign a consent form as well, just to make sure that nothing's going to go out the room and be discussed. When I first started doing the clinics, I was getting about 8 patients. Now I seem to be getting anywhere between 13 to 16 patients who want to attend, which is great. So that's good. So the patients that I tend to invite are newly diagnosed within the last 12 to 18 months. I could go back further, but it would take a long time to get through all those patients. As I say, at the moment, I'm having anywhere between 13 and 16 patients. So I normally have a facilitator. Unfortunately, she's not on the meeting today. She's unable to attend. But basically, she introduces the session and what's going to happen. And as we were informed earlier, the clinician comes in, that's myself. And we discuss CKD and what it is, and go from there. Next slide, please. So this is a results board which the facilitator brings up for them. It will show the patient's name, which we only put their first name, we don't put their second name in. They've got their BMI, their HbA1c, their blood pressure, cholesterol, EGFR, and the urine ACR. And as you can see, it is very similar to the diabetes one, and that's because diabetes and CKD are interlinked as well. A lot of patients don't know what their EGFR is. They go, well, how have I got CKD? Or they didn't know they'd got CKD. So that's where I kind of explain about the EGFR, what it is, what we're looking at as well. And also what their blood pressure targets mean and what they should be, because a lot of patients surprisingly don't know what their blood pressure should be or what their HbA1c range should be, which is why I've put it in the results board as well. Next slide, please. So when the patients attend, I talk to them about how the kidneys work, because a lot of patients don't realise that the kidneys regulate our blood pressure. They're responsible for our red blood cells, our hormones. They don't just get rid of waste. They do a lot more than that. I explained to them how we diagnose CKD as well. It's not just a one-off reading. We basically have to have more than 2 EGFRs, less than 60 over a period of 3 months. And what is the ACR? Because some patients can have a perfectly normal EGFR, so their EGFR might be above 90, but their ACR, which is the albumin-creatinine ratio, is in the range of CKD, so above 3 or above 30. And that's where I have to explain why that matters, because the ACR is a good indicator of the cardiovascular risk, and that's why we need it, and a lot of patients don't realise that either. I talk to them about lifestyle and, you know, find out what exercise they do or if they want to stop smoking, and obviously discuss about blood pressure control and CKD, because it's really important that I do encourage them to purchase a monitor if they can, just to keep a monitor on their blood pressure control, which is good. Most of them have got a blood pressure machine, but they didn't realise that the kidneys were also involved with the blood pressure. Okay, so in the packs, when patients attend, this is what they take home with them. So they get a CKD health checkbook, which is really good. The Kidney Care website, I can really recommend that for educational purposes, for staff as well as patients and the relatives and the carers. And also they get a recipe book, which has got low salt diet, which we talk about as well. When patients are looking at the results board as well, sometimes they kind of think, well, what do I want to change? But it gives them that opportunity to look at what their blood pressure is, what their BMI is. And it's quite useful. And a lot of patients have said to me, oh, I didn't realise my BMI was that, and I didn't know that was the situation. So it has been useful having the results board. A lot of good feedbacks come from that. And patients do tend to write it down, because not everybody's got access to the NHS app where they can look at their results. So that's really good. Next slide, please. Thank you. So what's been the impact? Basically, efficiency gain, definitely, because we're trying to be net zero, so using less energy consumed, more energy efficient. And previously the consult times were 30 to 45 minutes with a patient, so that's quite a lot of time, whereas if you've got a group of patients all in the same room, it reduces that time frame and less explaining over and over again. Also, the facilitator monitors the time and the running of the session, because sometimes if patients have got questions, they'll kind of say, oh, I want to ask about this, or I want to ask about this, and we have to tell them about the car park, and we'll come back to it. I also have a colleague of mine who is a diabetes specialist nurse, and she has dropped in on my sessions as well, which has been really useful. And we again talk about diabetes and how that can affect the kidneys, and getting better control of the diabetes and the blood pressure. It will have a better outcome cardiovascularly as well. Next slide, please. So the patient outcomes, I feel it has definitely been positive feedback that we've had from patients. I think the only negative I've had is, can we have a cup of tea with the group clinic? And it's kind of like, no, we can't do that, unfortunately. But the feedback has been very positive, which I'll show you shortly. And also, as I say, patients don't know much about CKD. And staff haven't really known much about CKD, so it's nice to educate them and answer any queries that they have, because when you say to somebody you've got chronic kidney disease, it can be quite scary to a patient. The word chronic itself, a lot of patients think, oh my gosh, I'm going to have to go on dialysis, or I needed a transplant, and that's the first thing they think of. So I have to reassure them straight away and say, look, chronic kidney disease is basically, it means you've had it for some time. The kidneys aren't working as well as they used to, but they are still working. And it reassures them. Also, I think it empowers the patients to make those healthy choices. As I say, a lot of patients don't realise that their blood pressure is regulated by the kidneys, and they're kind of, oh, well, that's why I need to do that then. I need to look after my blood pressure a bit better. Also, social well-being. So a lot of patients are elderly, or unfortunately they don't get out as much since COVID. So it's quite nice when we see patients come in and they're chatting amongst themselves before the session starts. Oh, I've just been diagnosed. Yeah, I've just been diagnosed, which is fantastic because they don't feel alone. And a lot of patients, when you give them a diagnosis, they can feel very alone. It's okay signposting them, but I think they need that reassurance, plus to know that there's other patients in the same situation as them. Also, it identifies any problems. So patient might look at their blood pressure on the results board and they'll say, oh, I didn't realise it was that high, and I was told to come back for a blood pressure check. And I'll say, well, if you've got a meter at home, do some readings, and they'll be quite happy with that. And somebody will say, oh yeah, I bought this monitor, or I bought this. It's very interactive, which the patients love as well. As I said earlier, it's less repetition in a group setting because they're all there together. They've all come for the same thing. They are all wanting to know more about CKD. And also time to answer the questions or the concerns that the patients may have, which is part and parcel of it as well. If they've got the knowledge, then they're able to do something to help themselves as well. Next slide, please. So what I did, or what I do, is I give them a feedback sheet as well in their education pack. And I asked them if they wouldn't mind completing it. And thankfully, touch wood, nobody has said, no, I don't want to complete it. But I've had some great feedback. There's a score as well of how much they knew about CKD before they came in and how much they knew at the end of the session. And they tend to score, it's from 0 to 10, 10 being they know about CKD. So they score themselves before. and then they score themselves after the session, and it's fantastic, and it makes me feel like I'm doing a good job when I see those scores have gone up a bit, because they have a bit more understanding. They feel more well informed. These are some of the actual words that the patients have used on the feedback forms, which has been lovely to see. As I say, a lot of patients do feel alone, so when they come together in a group clinic, they can bounce ideas off each other as well. So I think that's quite positive feedback, and I've only done, how many have I done now? I've done 4 sessions. I do 1 a month at the moment, because I do heart failure reviews as well, and CKD, and you know, coding patients. So at the moment I've done 1 a month, and I've got the next one arranged for the end of this month, which is where I've got 18 patients, so I've got a little bit more, which is fine. The more the better. And then I've also got the session booked for the end of the month as well, the end of June as well. So I try and book far ahead, and that way I can get myself ready for the education session and get everything prepared, like the education packs and things like that as well. Next slide, please. So what are our steps for the future? Our aim is to run more group sessions for other health conditions or combine them. As I say, diabetes and high blood pressure are the common causes of CKD. So I think what we ought to do as well is combine it and run bigger group sessions for other health conditions as well, and expand the group size. QOF work is incorporated into the education sessions, because I will say to patients about cholesterol, we talk about cholesterol and why that's important, and also we talk about why it's important to go on a statin or be offered a statin at least, because of the CKD and the cardiovascular outcomes and risks. So yeah, we do cover QOF work, but hopefully we'll incorporate some more QOF work into the session. I also show patients what's called the kidney failure risk equation tool, which is really useful. That shows patients the likelihood of them needing a transplant or dialysis within 2 and 5 years, dependent on their ACR result and their EGFR. And a lot of patients find that so reassuring to see. So it's a good way of incorporating that as well. At the moment, that's not on QOF. Whether it comes in the future, I'm not too sure. We'll have to watch this space. But the KF RE should be done anyway, as a rule.
I think that might be you, mightn't it?
Done, yes.
Oh yeah, pretty much. So, have you got any advice you want to for others wanting to set up CKD groups, Carrie?
Yeah. So basically, if anybody's thinking about doing it, definitely do it. If you've got the opportunity, or you have the opportunity, please do it. Patients are responding really well to CKD, and I think it's the future. Because of, you know, the aging population, we're getting more diabetes, we're getting more high blood pressure, and I think if we can combine them and utilize the resources we've got, I think it's definitely useful, definitely.
Fantastic. So we've got, there's been quite a few questions in the chat, and I've answered quite a lot of them where they're kind of processy questions. Okay. But I think there's one which is really interesting for you to answer, which is from Jackie. And Jackie said, So I guess really for those people who are in the audience today who really this group clinics are a really new idea for them.
Yes.
It's really hard to imagine, how do you do those one-to-one discussions in this group environment? Because what Jackie's hinting at is, actually, are you really only doing education, or are you actually reviewing each of the patients and actually having a conversation about them? And, so how do you do, doing changes to their meds and all that kind of thing? Yeah. And we know that this is the whole thing, isn't it? People get so confused with this. So just explain, Carrie, as a clinician, how is this possible? Is it feasible? How does it work?
Okay, so no, thank you for that. I didn't explain very well on that. But when we do the one-to-one, so when patients are in the group setting, myself as a clinician, the patients will talk amongst themselves, which is great, and I go to each patient individually. And I'll ask them, is there anything they want to address? Do they want to look at their blood pressure? Or I'll have their results with me as well on the form. And I'll say, what do you want to do? How do you want to do it? So it's setting goals as well as looking at their medication. So if a patient is CKD, they've got diabetes, I sometimes suggest dapagliflozin or an SGLT2, have a chat with them. And then if they want that, then I'll request that from their GP. If their blood pressure is a bit high, I'll ask them to monitor their blood pressure for 4 days and send their readings back into the surgery. And then we can address their blood pressure medication. If they've got a high ACR, same again, I will ask if they're definitely taking the medication, or are they struggling with anything with their medication, because a lot of patients do say, oh, I do forget this, or I do forget that. So that's been interesting. And then I just go,
can I ask you, Carrie, on that? Do you think that they're more honest in the group?
Yeah, definitely. Definitely.
Yeah, that's what everybody says. It's almost like it's okay to admit in a group that I'm not taking my medication. So 100%. you get to the bottom of the story so much quicker, don't you?
Yeah, it's a safe space, they feel, I think. And I don't wear uniform when I do it as well. I wear normal dress, and I think that helps as well, because I'm not just seen as a clinician and they don't want to ask. Like, I had one patient who'd had problems with cholesterol with their statin, and I suggested, well, try taking it at night, see how you get on. And a couple of weeks later I rang him up to do a follow-up call just to see how he was, and he was like, so much better. And that was just so nice, because he was honest and said, look, I'm struggling with my cholesterol, but with my statin, but I've not told anyone. So you just go round each patient. I just go round each patient and basically ask them what they want to address, because some people don't want to address anything, and that's their choice. I can only give them so much information, and it's whether they want to, if they're overweight, and whether they want to be referred to social prescribers or things like that, then I can do that as well. So I'll just jot down what they want to do, and then at the end of the session I literally type it up, refer onwards. If a patient wants to go on DAPA, I'll request it via the GP and so forth. If somebody wants the blood pressure medication, I'll let the GP know that they need to consider increasing it and stuff like that. So hopefully that answers.
Yeah, and the thing is, it's a new skill that you're learning, isn't it? You get used to it. I bet when you did your first one, you were a bit like all over the place. But by the time you've done about 3 or 4, it's like, you can't expect to be perfect immediately. No. But most people say once they've done 3 or 4, they're kind of like, I get it now, and it works really well. So definitely. And so Sam's asked, how do you have enough time to review each patient? And if you don't mind, I'm just to move us on a little bit, I'm going to sort of share a little bit, and you tell me if this reflects your experience. So what we find is, because you have that group discussion up front and you've dealt with people's questions and their queries, because you ask them what they want to talk about, once you come to the one-to-one discussion, that can be quite... Oh, somebody's not muted. If you wouldn't mind just muting yourself. Helen, you able to find that person who's not muted?
Yeah, I'll have a look.
Thank you. Sorry. So basically so because you've dealt with a lot of the general stuff, you only need a very short one-to-one with each patient.
Exactly.
Sort of maybe 5 minutes, maybe less. And by the time you've spoken to a couple of people, the rest of them will say, you know, actually, I haven't got anything else that I want to talk to you about, you know? So that's really, that works really, really, really well. And it saves so much time. The other thing is, I think it's really worth you just telling us very briefly before I move us on to the next little part, you know, what's it like for you as a clinician? How does this compare to doing, you know, I mean, couldn't believe it when you said 13 to 16 people you're getting now. So you're spending 90 minutes, not even as much as 90 minutes as if your facilitator setting it up with 16 people. If you had to do a one-to-one with each of those people, one after the other.
2 days, 3 days appointments it would be, I think.
So
it definitely does make a difference. Definitely for me as a clinician, at first I was daunted. Like anything new, everybody, you know, we're all kind of, oh my gosh, how's that going to work? And it definitely does work, and patients are more open, and definitely I feel quite honoured to do it, and I feel you know, the patients are getting the best care they can, in terms of, they definitely, you know, as a clinician, they don't just see me as just the CKD nurse, they see it as a holistic thing, a whole thing. So they're looking at exercise and everything, which some people have never thought of before. So I feel honoured as a clinician to do it, and also the fact that it has reduced appointment times, because those appointments would be taken over 2-3 days to do all of that. It's definitely helped with that. So yeah, makes me feel proud and makes me feel like I'm doing a good job and giving them the time as well to do it.
Absolutely. So I and that's what people say, it really restores a sense of joy to their practice. You know, it gets rid of that repetition. You feel like you're really getting to know the patients, and you know, sort of see them in their real life, you know, kind of context. It's really rewarding, isn't it?
I think what else is nice as well is the continuity. So I would phone the patient and tell them they've got CKD, offer them the education and group clinic sessions, and they're like, oh gosh, yes. And I think I've had 2 DNAs out of all the patients I've seen, and that was because, bless them, they did ring me to say, I can't make it, my so-and-so's gone into hospital, or somebody, you know. And I think in terms of DNAs, literally 2 patients out of groups of 13 to 16 is not bad at all. They're definitely more forthcoming and wanting to come.
Absolutely. We're getting so many questions in the chat about the process. You know, clearly we've got lots of people who maybe haven't had any experience of group clinics before. So it's really I mean, guys, almost all your questions are covered. Well, all the questions are covered in the training that we offer. So and it does definitely help to get training. You know, you can do this without training, but you will probably take a huge amount of time to overcome a lot of the barriers to making the change that we have designed the training to address. So it's really worth it, and we can help you to make the case for training if there isn't any funded in your area, but there are lots of places where there is. So I'm just going to move us on to the next slides, because we said that this was about hypertension as well as CKD. And it's really interesting. And actually, Carrie and I were talking before, and I was Carrie's emails on that screen there. Carrie, do you maybe want to pop your email into the chat as well? And would you mind just muting yourself whilst I just for a moment? But and actually, what really struck me when I was preparing for the webinar, and I changed what I was going to talk about, because I was going to share with you some examples of where people have done this for hypertension. But what actually really occurred to me is that the results boards for diabetes, hypertension and CKD are almost identical. And actually, Carrie has identified that herself and said, you know, it'd be great to be doing mixed groups. So my proposal to you guys today is that maybe what we could be looking at is a completely different way of supporting people who've got this kind of, you know, different stages on the journey of having this kind of metabolic syndrome. And just to illustrate the point, I'm just going to show you in quick succession 3 different results boards for diabetes. Okay, so look at the biometrics: BMI, HbA1c, BP, cholesterol, CV risk, EGFR, urine ACR, feet, eyes. That's our 8 pathways that we have to do for QOF. Next one, CKD, I think is the next one. BMI, HbA1c, blood pressure, cholesterol, EGFR, ACR. So basically, it's almost the same. Yeah. Next one, hypertension. Almost the same, yeah, as well as lifestyle factors. And if you were to combine a sort of lifestyle medicine approach with the metabolic syndromes that are covered by all of these conditions, you could actually be delivering group clinics on a weekly basis, probably 2, maybe even 3 group clinics a week, and supporting people with diabetes, hypertension, CKD to all so much better understand what is going on with them and these core biometrics that they should be taking heed of. And just to tell you a personal story, so we are often people often say to us, why don't you have patients come along to your webinars? Well, today you have got a patient with CKD, and that's me. So I do have actually a diagnosis of CKD. It's probably as a result of blood pressure, probably a result of being a bit overweight, probably a result of maybe drinking a little bit too much wine. I should think none of these things have helped. But I had no idea, as Carrie so clearly described, that I had CKD until I went along to have my flu jab, and I was also eligible for a COVID jab. And the practice nurse who was doing the jab said to me, why are you eligible for a COVID jab? Oh, well, you know, it must be because I said it was because I've got high blood pressure. She said, no, that wouldn't make you eligible. And then she looked at my records and she said, oh, you've got CKD. That's why. Now, I happen to know what CKD means because of what I do, but I was completely floored by that. I could not believe that I could have a diagnosis of something and not know it, and yet my practice had got me coded as having that condition. And I spent the next 2 or 3 days trawling through the internet, getting really worried. What you describe is exactly how I felt. Oh my God, I'm going to go into renal failure. I'm going to need some kind of, kidney transplant. I was absolutely terrified. And yet then when I spoke to one of the clinicians who works with us as an expert mentor and runs our training, she said, Georgina, you're more likely to die of a heart attack don't worry about it, but you do need to get your cholesterol managed properly. She gave me a really good coaching session, and then I went to see my GP and had a good go at them and said, what on earth are you doing? Why are you behaving like this? And as you can imagine, I also pitched her group clinics whilst I was in the consultation as well. So, you know, but actually I've got high blood pressure. But if I was in a group clinic with somebody who had diabetes, who was being talked to about how they, or supported around looking after their feet, you know, their kidneys, etc., I would probably it would motivate me even more to think about managing my blood pressure, losing weight, etc., etc. So I think that the challenge that we have here in delivering QOF and doing that in a person-centered way is to stop putting our patients into boxes, recognize that they've all got these same issues that they need to manage in terms of lifestyle, whether they've got hypertension, CKD, or diabetes, and start offering them a different way of managing their condition that connects them and helps and empowers them. And I hope that that's something that you'll maybe just go away and think about, because we need to improve access. But I'll tell you what, you know, triage is not the only way to improve access. If you could increase the efficiency and of what you do in terms of planned care, and if you could increase the effectiveness of that planned care in empowering your patients like me to actually make these changes, and you know, that would be the way forward, in my opinion. So would really welcome your thoughts in the chat about that. I feel very, very passionate about this because that was not a good experience that I had, and I don't think I'm alone in that amongst CKD patients. So pop some, has there anyone else got any more questions? I haven't been able to look at the chat whilst I've been talking. Helen, have you picked anything else up?
I've been picking things up. It's mainly people who are interested in training now, so I've just been responding where we haven't got areas.
Brilliant. But yeah, if you think that what I've just said about that sort of combined model covering all different kinds of conditions sounds like a good idea, if you'd even like to maybe pilot that, and you know, maybe we'll pick up about that, Carrie, after today, do let me know, because if there is training in your area, I do think that's something that would make a lot of sense to scope and trial. So I'm going to be quiet now, and I'm going to hand over to Helen to start to bring us to a close.